Thank you everyone for joining us this lunchtime. It's a real pleasure to introduce our speaker this afternoon. It's Richard Windle. Richard is currently clinical manager at Diatec and is also chair of the BSA. Prior to his current role, Richard spent many years working in the NHS as a clinical audiologist, building extensive experience across clinical practice and audiology services. His career has given him a fantastic breadth of experience from frontline clinical audiology through to leadership within our profession, and we're delighted to have him join us today. So Richard, thank you so much for giving up your time and sharing your knowledge and expertise with us. We're really looking forward to hearing from you.
Everything up. Can you, I'll just check with Jayne and Zoe. Can you see those slides okay?
Yeah, that all looks great.
Okay, great. So, hi, I'll dive straight into it. I know probably you're all busy over your lunch and got a patient soon, so I will crack through. I think probably if you do have desperate questions that you're really unsure about something, perhaps just raise your hand and Zoe and Jayne can shout if you see a hand, because I won't be looking. And we'll crack on. So my name's Richard. As you said, I'm clinical manager at Diatec. I run the clinical team. The clinical team basically run a lot of training courses for Diatec, and we also do clinical support. So if you're buying Diatec stuff, we'll be there training on implementation and supporting you, and particularly any clinical questions. So not just technical questions, but actually how do I use this in my clinic is the sort of stuff that we answer day to day. So just quickly, I will explain who Diatec are, because that might be a new name to you. If you asked me 6 months ago, I'd be saying, hello, I'm Richard from Intraacoustics. We still are Intraacoustics, but Intraacoustics is part of a bigger group, the Demant Group, based in Denmark. Demant owns a lot of other companies which you may well use, particularly in private practice, such as Mako, Medarex. Many of you will know Guymark, possibly Acoustic Metrology and GSI as well. Those have all been part of Demant for a very long time. So in the UK, all we've done really is just try to have a single support sales force and calibration service that covers all the same things through the same people. So nothing that much has changed, although it's just easier to access us for all of that stuff, basically. So that's Diatec. Today, we're going to talk about speech testing. I'm going to kind of take a bit of a diversion, off into a bit of theory about how do we actually understand speech and what is it we do to understand speech as humans. Really, because that's kind of important to know what we're testing and what implications it has for what we're testing. I'll do a bit about why we do speech testing and how we actually do it. It's kind of difficult to demonstrate on a webinar other than say press the start button. So we're going to talk a bit more about the theory behind it and what it's actually measuring. So first, I'm going to talk about how do we actually understand speech. And I'm going to start with this phrase, so eat your raisins outdoors. I picked that because I found a nice picture of what it actually looks like as a sound signal. And I'm just going to talk through how that gets from a voiced phrase to actually understanding a meaning in our brains. So if I say the words eat your raisins outdoors, all it is a bunch of molecules moving around in air. It's just vibrations in air that reaches our ear. And somehow out of all that mush, we've got to make sense of it. So we have a fantastically complex auditory system, and as that reaches both ears, what your auditory system has to do is to look for timing information, the different times it's arriving between the two ears. It's got to define the frequency of the sound and then the location of the sound, and that in itself is a pretty complicated process. Once we've done that, we have basically something looking like this picture in the bottom right, which is a frequency spectrogram somewhere in our brainstem. And then we have to start recognizing things. So we have to start recognizing things like phonemes, so each letter or sound of the words. We then have to start building up words in our heads and recognizing words. And then that has to form sentences or phrases that are meaningful groups of words. We have to do something complicated in speech processing called thematic role assignment. And in very simple terms, probably oversimplistic terms, that's things like who, what, and how. So the word you understand is a person, it's a thing, it has certain characteristics, and it can do things. Raisins, you understand, is a food, it has a taste associated, and eat is an action, etc., etc. So you're starting to assign roles effectively to each of those words and phrases. And then eventually you actually have to get to discourse comprehension. And that's a holistic understanding of the message and the key messages. So at that point in your brain, it may cease to be a bunch of words. It may just be an emotive or visual understanding of what's happening, and you may just form a picture and an understanding of it. So to make all of that work, a lot of things have to happen. So to get to timing, frequency, and location in our auditory system, we have to have something called processing speed. It has to do it quickly. It has to be really accurate in timing about what sounds arriving when. There has to be an element of coordination. Most obviously, you've got to put two signals together from each ear, or binaural processing. And then something called modulation detection. We'll come back to that a bit later because that's important in some of the tests we can do. If we want to start recognizing phonemes, then we actually have to have a template of phonemes stuck in our head. So if you go into the kind of famous foundational studies behind this, there's a particularly famous study looking at American and Japanese babies. So when they're born, babies can understand pretty much, or start to recognize any phoneme in any language. Over time, after about 6 months, though, it starts to prune out the stuff it's not hearing. So at that point, an American baby will understand English phonemes, and a Japanese baby will understand Japanese phonemes and start losing the ability to understand the phonemes of different languages. We need to build that into words. So if you're going to understand words, you actually need a dictionary in your head, which we'd all know more commonly as our vocabulary. And we need to start doing things like conflict resolution. So if I'm sat in London here right now, I would say a big red double-decker thing is a bus. If I move up north, it might be a bus, or if I move to Bolton, it could be a buzz. So it might be pronounced in a way that we don't immediately understand that matches our dictionary in our head. So we have to do some conflict resolution about working out what that thing is and correct it in the meaning. If we're going to understand sentences, we actually need to understand grammar or syntax in speech processing terms. So we actually have to have a set of rules in our head about what order do we expect words in. And then as you get higher up, you need to do things like prediction. So we're constantly predicting what we think is coming next. There's inference that's based on lots of models and frameworks in our heads. And we're also starting to use visual and emotional inputs. So a visual input, an obvious example of that is speech in noise, where we're all natively doing lip reading. So if you think of the McGurk effect, I don't know if any of you understand what that is, but go and Google it. The McGurk effect is showing that your vision will override your hearing, and that's useful. It's not a mistake. It's useful in speech in noise. But also we need to take lots of emotional inputs. So if I say, eat your raisins outdoors in a nice, calm voice, it will mean something very different if I shout it at you in a demanding way. And that will change the meaning of what I'm saying, or the urgency of what you understand about that phrase. So a lot of stuff has to happen in our heads, between our ears and our brain. So really what we're doing, we're starting with some acoustic analysis of frequency and time, and we're working further and further up the system into cognitive functions. It's really changing sound, or a mush of pressure vibration that reaches your ears, into something with meaning. So that depends a lot on our cognitive functions. And the cognitive functions that, particularly in research studies that associate with speech understandings, are things down the left-hand side here. So things like lots of different types of memory. So episodic memory has to do more with context and emotion. We need long-term memory because we need to store a dictionary in our heads. Short-term working memory is just something that's working on what we're processing at this moment in time, and then it's thrown in the bin. So a little bit like random access memory on a computer. Processing speed is just how fast your brain works. and then something called neural inhibition. So in, again, probably oversimplistic terms, if one set of neurons is working on one thing, it needs to tell another set of neurons, don't do the same thing, go and do something else. Otherwise, that will be very inefficient. So a lot's happening. You don't need to understand all the details. Sorry, lots of detail there, but it's complicated is the bottom line of this. And it depends on lots of things in auditory processing and cognition. So that's nice and easy. That's complicated, but that's a simple scenario. If we go into real life, of course, somebody may be saying the sentence, eat your raisins outdoors, but then you've got two other people talking and some noise in the background as well. So all the same things have to happen, but you have to decide which of those people talking do you need to listen to. And that depends on another set of cognitive functions, sometimes called executive functions, but in particular attention control. So I need to decide which of these people I'm going to listen to. And that actually feeds right back down through the brain, through the auditory system, and changes what the auditory system does. So it's going to decide to process the sound coming from one person in preference to the other sounds. And that reaches right back down to our ears. So if we actually kind of try and convert that kind of notional picture into what it actually looks like, and I apologize, there's going to be lots of pictures of lots of wires and spaghetti all over a page here, but essentially there is our, if you go and read a textbook, there is our ascending auditory system. So that's between our ear and our auditory cortex. It's super fast, it's very complicated, it does all the acoustic processing, particularly in time and frequency domains, puts together two ears and does the localization before it gets to the auditory cortex. That's probably a simple picture of it. We then have a descending auditory pathway. So that's top-down control. So this is if I've decided to listen to one speaker, I need to tell the auditory system which one of these sounds I want it to process. So it's going to preferentially process some sounds rather than others. And that system actually reaches right back down to the outer hair cells in the ears. So it actually kind of quite profoundly changes how our ears and auditory processing system are working with speech. Layer on top of that, as soon as it gets to the auditory cortex, it's really only working on phonemes at the most, and then your brain has to do the rest of the work. So from phonemes, you've got to get to the frontal cortex, which is conscious understanding of what somebody's saying, what it means, and what it means in that scenario that you're currently in. Excuse me. So if we think a bit of science, there's something called the iron law of systems, which basically says the more complex and finely tuned the system is, the more likely it is to go wrong. And that's particularly true of auditory processing and speech processing. There are lots and lots and lots and lots of things that can undermine your ability to understand somebody speaking. So one of the things other than hearing is your level of cognition, and so I'm just going to talk a little bit about what happens to us with age as we age normally. So this is not about cognitive impairment, it's not about dementia, this is about normal aging that's happening to all of us. So for most of us throughout kind of early adulthood to late adulthood, if we do lots of psychometric tests, we actually tend to end up with the same score throughout life. We don't decline. However, if you lift up the hood and look underneath at what's happening, we do things differently throughout age. So something called crystallized intelligence, which is more to do with long-term memory and experience, actually increases throughout life. Whereas fluid intelligence, which is just to do with more speed and processing, unfortunately for all of us, declines throughout life. And we sadly, very sadly for some of us who are getting past this age, we peak at around our early 20s and it declines from there on in. And this affects how we all process speech. So if we look at crystallized intelligence, that includes long-term memory, episodic memory. Those tend not to decline with age. If we look at fluid intelligence, processing speed, actually just the speed at which our brain and auditory processing system works, slows down. Short-term memory declines and inhibition declines, so we're less efficient at processing things. And what that means in terms of speech is that throughout life, our understanding or our vocabulary gets better, our syntax gets better, our experience gets better. So we're better at developing shortcuts or understanding where things are in different situations. But underneath it, the speed at which we're doing things, our binaural processing, localization, attention control, segregation of sounds, all of which add up to speech and noise, all of those decline normally throughout life. Even if you have perfectly normal hearing, those things still decline. So that's going to affect speech processing. So if we look at what actually happens with age, so each of these red dots on the screen, I'm sorry, there's a cloud of dots, is hundreds and hundreds of people, and there is their measured cognition throughout age. So along the bottom here, we've got age from 20 up to about 85, 90. And up the left here, we have a standardized score of their cognitive abilities, particularly fluid cognition. And what you can see is that on average, we decline with age, basically. Sorry, your pictures of all the people on the call are covering up the words. Excuse me. So two things happen. On average, we decline with age. But also, as we get older, the range at which, or the speed at which we decline is different for different people. So some people decline slower than others. So as you get older, the range of performance, the range of cognitive performance increases. So what happens is that if a person walks in the room, you can say that they have probably worse cognition when they're 80 than they had when they're 20, but you can't actually say how good a person's cognition is when they're one of your patients. So if you just look at the 80-year-olds, you can see that some 80-year-olds, I don't know if, can you see my cursor, Jane and Zoe? Yes, you can. Okay. So if you look at the 80-year-olds, some of them actually have just as good or better cognition than some of the 20-year-olds. But a lot of them are worse. So if you have an 80-year-old walking in, they could have very poor reduced cognition due to normal aging. And again, this is people with normal aging. This is not the cognitively impaired group or the dementia group. But some 80-year-olds will have very good cognition, better than some of the 20-year-olds. So you can't just use age as a predictor of somebody's cognition, which is a problem for us. So basically, at a population level, fluid processing declines with age, but at an individual level, we just simply do not know how good they are cognitively, and therefore how good cognitively they're managing to process speech. So what do we actually measure with speech testing? So essentially, what we're measuring with speech testing is everything I've described so far. You are measuring somebody's hearing, you're measuring their auditory processing, and you're measuring their cognition, including their attention control. And that's why speech processing is useful, because that's not something we do with any other test in audiology, certainly not with an audiogram. So what will affect speech understanding? Well, a hearing loss, obviously, will affect speech understanding, but also cognitive change due to normal aging will affect speech processing. I'm far worse, age 50-something, at processing speech in noise. Believe me, you will have problems speaking to me in a noisy place. And that's just normal aging. Dementia and mild cognitive impairment will obviously affect speech processing. Different types of dementia will have different patterns for speech processing. So, for example, Alzheimer's typically will mean that somebody will not be able to process speech at all if there's any other competing sound in a room whatsoever. Things that affect the pathway up the brainstem and through the brain, strokes, tumors, trauma, they will affect speech processing. If you can't do attention control and flip between talks very well, that will affect speech processing. So things such as autism, ADHD, anything that affects your attentional control will affect your speech processing, as will things that affect your neural connections. So ANSD, multiple sclerosis, anything like that, all of which will affect your speech processing, all of which will affect your speech test. So if you look at the hearing threshold and speech in noise. So along the bottom here, we have the average of your hearing test, your 4-frequency average of pure tone audiometry. And up the right here, we have your speech in noise score. So to some degree, hearing will affect your speech in noise score. However, I think if you pick one age, perhaps pick 60, you can see a PTA average of 60. Some people are actually doing pretty well with speech in noise, and some people are doing appallingly badly. So again, you can't use hearing alone to predict what somebody's speech in noise ability is going to be without doing a speech test. So speech in noise particularly, or speech generally, depends on both hearing and cognition. It changes with normal aging, but in extreme cases, particularly things like Alzheimer's disease, you will not be able to hear any speech where there's an environment with a competing sound or noise in the background. So as an individual walks into your clinic, essentially bottom line is you don't know what their speech ability is, their speech processing ability is. Here's a same but different example from my own research. So at the bottom here, we've got the pure tone average again, from good hearing on the left to right hearing on the poor hearing on the right. And up the left, we've got their average cognitive score. So poor cognition at the bottom, good cognition at the top. And the bubbles represent their quicksand scores. So a big bubble means they've got poor speech in noise or a big SNR loss. So a big bubble is poor speech in noise, and a small dot is very good speech in noise. So the worse your hearing gets, the bigger the bubble, or the worse your speech in noise gets. But also if you move down in cognition, then the worse your speech in noise ability gets as well. So it's an interrelation between both. Quicksand's not the best test for doing this, because basically the harder the task you set for somebody in speech and noise, the bigger the correlation you get with cognitive ability. So the more difficult it is, the more it's going to depend on cognitive ability. So that was a bit of a blast through the background about what are we actually measuring. So bottom line of that, I know there's lots of dots, lots of lines and complicated wiring diagrams. Bottom line is of understanding all of that is speech depends on hearing and cognition. And that's essentially why we're doing speech testing, because we can't predict a specific patient or client's speech ability with just a hearing test. So if we only did audiometry, we'd measure the amount of hearing they've got, but we're really not measuring the quality of remaining hearing, or really the quality of their speech processing system to make meaning out of sounds. Audiometry itself isn't very good at predicting speech intelligibility, so it doesn't measure the whole hearing pathway. So for me to press a button when you play a pure tone, I need one sadly frayed neuron clinging onto my ear and somehow making it through to my brain. But if I put a speech signal through that same system, I'm just going to get garbage, basically. So for the speech testing pathway tests all of that pathway up to your frontal cortex to understanding and being able to repeat a word. The other thing that audiometry doesn't tell us, or just the degree of hearing loss doesn't tell us, is how do we set all these fancy features on a hearing aid? So an audiogram will tell us what sort of gain we need on a hearing aid, but all the other buttons and knobs and whistles you have with a hearing aid, it doesn't tell us anything about where to set them. So speech testing does give us some information with that. So after audiometry, you have no information about cognitive status. You don't know somebody's speech recognition ability. That means you can't set appropriate expectations for hearing aids. So for example, if I've got perfect hearing but very poor speech and noise ability, because I just can't cognitively process it because of auditory processing or cognition, then no amount of gain on a hearing aid is going to change that. So you can't set the expectation that if you walk in a noisy pub or restaurant tonight with your hearing aids in, you're going to get speech and noise back, because that isn't going to happen. And your client's going to be back next week saying, these hearing aids don't work. So you need to use it to set reasonable expectations for the status of that person, and to set some of those parameters that might help them in different situations. So speech testing gives you some useful information. It improves counselling. It helps you set clearer expectations, because if their speech and noise perception is undermined by normal cognitive change, hearing aids aren't going to fix that part of the problem. And you should be clear about that when setting expectations. And it improves overall hearing aid fitting of giving you other options that may help them. So there's lots of different ways you can use speech testing. You can use it in a diagnostic sense, management, validation, or counselling. So a diagnostic application for this may be that, sorry, I'm waiting for my builds to appear. Excuse me. So in a diagnostic application, you may particularly use speech and quiet tests. So that may prove that a person has worse speech recognition ability than you would expect from the audiogram. It may also show that maybe they have worse speech processing in one ear than the other, even if their hearing ability on an audiogram is the same between the two ears. So that might tell you that there is some processing issue, there is some unilateral pathology, or it could be that somebody's got binaural distortion. In other words, they're struggling to put the two signals together between one ear and the other. So in complex clinics, I've had quite a few patients where they've been given binaural hearing aids. They have similar hearing in both ears. But what you find in validation process during a complex clinic is that if you put any gain in one of their ears, they cannot hear a thing. And actually, in those cases, what you find is that they do better with one hearing aid than two. So there are cases that happens. Now, you could do that with speech testing. You can just do it in validation by turning off one hearing aid and then the other and seeing what their performance is. If we move into speech testing and management, well, this is about using speech testing to set expectations and also set appropriate gain and hearing aid parameters. So as I've said, hearing aids can address hearing loss, but they can't necessarily address anything to do with speech and noise performance due to cognitive issues. Your hearing aid is not going to fix your auditory processing system or your brain. Your hearing aids may actually make it worse. So if you use over-aggressive programming, you can actually cause so much distortion that they actually find it harder to process the signal. And so sometimes you need to think about, can I clean the signal up if that's a problem? It may also lead you to think about accessories for speech and noise to increase the signal to noise ratio, such as microphones and other things that might actually be better solutions than the hearing aid themselves, or actually just directionality in the hearing aid. Another use of speech testing is just invalidation. So you can look at objective benefit, and I know a lot of you may use that, particularly in the private sector, of just looking at aided versus unaided benefit, and that can be done with speech and quiet or speech and noise. Just to show you what might happen if you do that, and this is just based on, it's a sort of an accidental finding of one of my research projects, which wasn't what the speech project was about. But here is some aided benefit from speech and quiet testing. So the aided benefit up the left-hand side here is just the score they got for aided speech and quiet minus the score they got for unaided speech and quiet. And as you can see, basically what happens is the worse somebody's hearing is, the more benefit they get, the more improvement in speech and quiet they get from wearing the hearing aids. One of the other things you might notice is that for some people with fairly low hearing loss, you might actually find they don't get a benefit. And I'm not sure that that's to do with a problem with the hearing aids. That may just be to do with the fact that there's some natural variation from test retest between the tests. So it's a bit of a warning that if you're going to do aided versus unaided benefit on somebody with a very mild hearing loss, it might not show a great result. So do be careful if you're doing that. Same picture again. This is the same picture for aided benefit, but for speech and noise testing. So you get a similar picture. You tend to see more benefit generally for people, but again, for speech and noise, people with a worse hearing loss will get more aided benefit than people with a mild hearing loss when you compare the two. It's harder to compare, and there's a wider variability of the dots on the page, and that's because there's a more of a cognitive element you engage when you're doing speech in noise testing. So that's a quick look. Speech testing and validation for adjusting the performance and preference in hearing aids. And I just remind you that objective performance and user preference are not the same thing. You can have a client in your clinic who may well prefer a bunch of settings and may well tell you these settings are far, far better, but they actually objectively do worse with those settings. So they may prefer something which gives them slightly less speech recognition ability than your preferred setting. And you've got to decide, do you go with their preference or do you go with your objective benefit and tell them to acclimatize to it? And that's got to be, that's a clinical decision that you've got to come to. I'd also say in validation, it also helps you to compare settings. So frankly, sometimes in a clinic, you do not know what to do. You cannot say with an individual in a room what is the best setting for them before you've set it. So part of the validation process is giving them options. So that may be you turn something off and turn something on and play the speech signal from your speech testing without actually measuring it, and ask them which one of those do you prefer. So occasionally, sometimes people will have strong preferences of something sounds so much better and easier to understand with something turned on or off. Or you can provide them with separate programs and say, try program 1 or try program 2 and come back and tell me which one's the best, because you can't replicate those real life situations in your clinic. So that's where speech testing comes in, or using the speech signal comes into the validation process. The final bit of speech testing is in counselling. So that's in just demonstrating that somebody benefits. They may come and tell you, I can't hear any better in a noisy place. So you may actually repeat an aided speech in noise test to prove to them, actually, you might not notice it, but you are doing quite a lot better. So stick with it and try and use it. That again, it aligns with their reported issues and their lived experience, and showing that you're trying to address those issues that are important to them, and it helps you to review their expectations of using hearing aids, which hopefully you've set correctly in the first place. So as you can see across that, speech testing can come in a lot of guises and a lot of uses. So that's all the background. I don't know if anybody has any burning questions. If I stop for a moment, stick up your hand before I go in the how to do it section. I can't see any hands. No, I'll crack on. So how would you do speech testing? Well, first of all, you've got to choose a test. And I'm assuming you, like me, will choose a test basically based on the fact that it's what I've got sat on my audiometer, because my department won't, or my company won't buy another one. But the key thing is you've got to choose, first and foremost, are you going to do speech in quiet or speech in noise? So if you're going to choose speech in quiet, you may choose to use sentences or words to do a test. And again, there's different uses for different things, but if you're going to use sentences, what you have to think about is how meaningful the sentence is, because somebody with good cognitive ability may be able to replace a word in a sentence that they didn't hear better than somebody with poor cognitive ability. So if I say I went to the shop and bought some apples, you can have a good crack at shop. If I say I went to the and bought some apples, you can probably have a good guess it was a shop. Some people with poorer, slower cognitive ability won't be able to do that in time before you've carried on speaking, and will just lose the meaning of the sentence. So if you want to just test audibility, you want to focus on words, not sentences. If you want to focus on cognition, sentences may be better. If you're going to use speech in noise ability, then the thing to remember is the more complex the task, the more it's going to engage cognitive skills. So QuickSyn, which is possibly something most of you have got, is reasonably good at engaging cognition. If you get into more complex cognitive stuff, then you probably need to use something that's probably not available on your average everyday audiometer. Other examples, which is similar use to Quicksin, a BK Sin, and Hint. But again, any of those are reasonably good speech and noise tasks. And I suggest if you've got one, use it. So there's a speech test. You're going to choose a speech test. What I suggest to all of you when you say, how do I learn to do a speech test, is go and find your audiometer, turn it on, press go, do it on yourself, and work out actually how easy it is. It's actually really quite easy to do a speech test. And most of us, I think, when I was sat in clinic years ago thinking, should I do a speech test? It was, oh God, can I remember to do it or not? Actually, if you've sat down and done it yourself a couple of times, you realize it's a very easy thing to do. And at least you build the confidence that actually, if I need to do it, all I need to remember is where to press go. And I'll remember the rest, because they're pretty straightforward on any of these devices. I'm going to do it on a Callisto because that's one of ours, and it's the one I've got pictures for. But essentially, if you're working on an Interacoustics Callisto, you press the speech test screen. You find the test, so you choose Quicksin for speech and noise, or in this case, I just choose AB word lists from the drop-down menu and press go, and the rest will be hopefully fairly obvious. I'm not going to do a demo because we haven't got time for that. I've already got 10 minutes, so I won't go off in that direction. But essentially, although I know, and Jayne's going to ask the question because she already told me, but there isn't a BSHAA protocol for this. I'm sorry. We would love there to be, but there are a lot of other things we need to have protocols for at the moment. There's a lot of focus on pediatric audiology, so we are throwing all of our eggs in the basket of doing things like play audiometry for peds, and actually having a protocol for doing hearing aid fitting before we get to speech speech testing. But essentially, a protocol, and it's pretty standard worldwide, is you start a speech and quiet test about 20-30 dB above their PTA average, so they can hear it. You present the word list, which the machine will chuck at you, and then you just score. So if you were to use this system, the AB word list and Callisto, it will give you two options for scoring. It will say correct or incorrect, did they get the word right or wrong, which is 1 or 0. Or it will ask you to score the number of phonemes in the word. So each word has 3 phonemes and you score each phoneme. So if you're going to do speech and quiet testing, I'll ask you, please do the phonemes out of 3. It's really easy. If I say ship, you get a sh, an I, and a p, and you get 3 points for that. And it's a much better way of scoring it. Once you've done a test, if it's above 50%, you decrease the level in 10 dB steps, and you do the next word list. And you just carry on dropping in 10 dB until it goes below 50%. And once you've gone below 50%, you can stop. And you can work out what the SRT, speech reception threshold, is. The machine will tell you it's the point at which it's the level at which they understand 50% of the words. And so in a diagnostic sense, you would expect that SRT to be within about 6 dB of their PTA average. If it's not, they've got a speech processing issue. If it's more than 12, you tend to take that as suggestive of a pathology that's causing a speech processing issue. And that's how you would simply do a speech and quiet test. Probably take you about 5 minutes. The result would look like this. So if you look along the bottom, that's the level of presentation. And really all we're looking for, the red line is the scores they've got at each of those levels. So the quieter you make it, the harder they find to understand it. And you're simply looking for the point at which they've got 50% right, which is essentially in this case halfway between those two lines. And your audiometer will tell you what the SRT is, and you just read it off. That's the key outcome of a speech and quiet test, is the SRT. It will also tell you if you were to carry on, you can actually go back up the scale and see what is their maximum speech reception score. Hopefully that will tell you it's 100%. So if you keep turning it up, they will understand 100%, which gives you confidence that if you fit a hearing aid, they should be able to hear everything okay for speech and quiet. In the older days, we looked for rollover, which is suggestive of a central pathology, whereas nowadays we stick the head in an MRI scanner, so it's much less done. But essentially, if you want to do more and look up there, if you look at what their maximum is, that helps you set expectations for a hearing aid. Because if it's not 100%, you're going to have to set expectations of what they're going to get from that hearing aid. On this piece of kit, there's also the C curve, and that is what you'd expect to see as their result if they had normal hearing. So you can see this person doesn't have normal hearing, and it shifted the curve to the right, so you would expect to correct it with some amplification. I'm not going to tell you what the M curve is because I can't remember. Moving on quickly. So if, again, you're going to do some speech and noise testing, very much the same thing, I would recommend you stick the headphones on yourself, open your audiometer, press QuickSim and go, see what happens, because that's the quickest way you're going to learn it. It's a really easy test to do. But essentially, what will happen is it plays some sentences to you. The starting level for speech and noise tests is slightly different. It's not exactly related to their hearing level on the audiogram. If they've got mild moderate hearing loss, you start at 70 dB and that's it. If it's worse than that, you have to work out a level that's quite allowed but not uncomfortable. Essentially, the actual level of a speech and noise test isn't quite as important as the difference between the noise and the signal, i.e. the difference in noise and signal. So typically you run speech and noise for 4 tests, or QuickSim for 4 lists or more. So for each list, what happens is there's a person speaking and there's a quiet noise in the background, and there's new sentences being provided each time you put a score in, and it increases the noise level, so it gets harder and harder and harder to understand the speech and noise. Anyone who's done QuickSim will tell you that most of your clients will go, "Ooh, it's in American." Not much we can do about that at the moment because that's all it's in. There are some variants internationally, but not in English. All you have to do in QuickSim is score the highlighted words. I'll show you that in a second. And essentially, you will be given a number for the SNR loss. So the signal to noise ratio loss represents the difference in signal to noise ratio for that person compared to a normal hearing person around the point at which they get 50% correct. So it's essentially an equivalent of the SRT for speech and quiet. So how much signal to noise ratio are they losing compared to a normal person at about the 50% point? So this is what the test will look like. If you press go, you will have a male or female that you choose saying the lake sparkled in the red hot sun. Your patient will report the sentence. Why they would say this sentence, I have no idea. But if they say the lake sparkled in the red hot gun, they've got 2 words wrong. So all you have to do is tell the system they've got 3 out of 5 words right. Once you click 3, it will carry on to the next sentence until it's finished the list. And that's all you have to do. So again, speech and noise test on your audiometer, nothing to be scared of. Again, it's a 5-minute test. I could give you a video. I haven't got time for it today, but what I'd really suggest to all of you, if you want to learn how to do speech and noise, speech and quiet, plug your audiometer in, give yourself 10 minutes, do it on yourself. It's really, really easy. And all you need to go away and remember is, oh yeah, if I go back there and press go, it's something that's easy to remember and easy to do when I go back there again, if I ever need it. What I'm going to do just for the last couple of minutes is talk about another way of testing speech, which some of you may have if it's on our kit, which is the audible contrast threshold. That's something, it's a speech test without using speech. And what it uses, if I flip on, is the fact that we are using modulation detection. And one of the key things in speech recognition is modulation detection. I just noticed I'm going to quarter past, so I'll carry on a few more minutes. If those of you have to dash off and see a patient, I'm sorry, I went on a bit, but just leave if you've got a clinic. Modulation detection is really down to the fact that we can break, in really simplistic terms, we can break the speech signal into 2 things, which is the modulation, the overall speech envelope, or we can break it up into all the detail underneath it, which we call the temporal fine structure. So if I look at a typical speech signal, it looks like this. The temporal fine structure is all the detailed timing and frequency information underneath it. The speech envelope is just the basic rhythm with no frequency information at all. The reason that's important is because the speech envelope is actually the most important thing when you're listening to speech in quiet. So if I say speech in quiet with a speech envelope, it'll sound like There's no frequency information, you're just getting a rhythm. If I add just a tiny bit of frequency information, maybe 3 or 4 frequency bands into that, most people with and without a hearing loss will be able to understand it. You need very little frequency detail to understand speech in quiet. However, if you're to understand speech in noise, you need much more detail. You need to be able to process all the temporal fine structure, that largely because that gives you the location and lots of superfluous information which you don't need for speech in quiet. So temporal fine structure, you lose the ability to process when if you've got a severe to profound hearing loss, you cannot process temporal fine structure. You can try and put it back there with a hearing aid, but you're wasting your time. They ain't going to get it. If you've got a cochlear implant, you've got 8 frequency bands, maybe, you can't have temporal fine structure. It's not there. That also is affected by cognition decline with age, so we lose that ability to process it. The speech envelope, however, is relatively unaffected by age, and it's relatively unaffected by hearing loss as well. So even for somebody with a really profound hearing loss, if you give them hearing aids, they may only hear the rhythm of speech. They may only hear but combined with lip reading, that can give them quite good speech understanding. So that's something, you know, for that particular group of people, you have to aim for differently with a hearing aid. Surprise, surprise, life isn't actually that simple. You can't really just break it up into envelope and temporal fine structure. Actually, what's going on is something much more complicated called spectrotemporal modulation. I won't try to explain it because I'll probably get it wrong, but it's a mishmash of all of those things above. It's a modulation in time and frequency all happening at the same time in your auditory system. That's important because that is what's measured by the audible contrast threshold test and helps us define how to set hearing aids. I'm going to flick through this, but ACT test is essentially measuring that spectrotemporal modulation. So it correlates really, really well with speech in quiet. I'm going to flick down through this slide, past the nasty noises. Essentially what it's doing is it's modulating a signal, and it's asking whether the client can hear the modulation. So what the test does at the top there, it presents noises continuously in a pulse of noise, and every now and then it inserts some modulation. So you'll hear a shushing noise, or you'll hear something that sounds like an ambulance noise, like a siren. The siren is the modulated signal. So you tell the patient, press the button when you hear the siren. So much like doing a pure tone audiogram, you give them a lot of modulation. If they can hear it, it drops down, gives them less, drops down, gives them less, until you establish a threshold. So it's a very quick test. It takes 2 minutes. This is what it looks like when you're doing the results. Is you give them a nice, easy to hear siren. It gets harder, harder, harder until they can't hear it. Go back up, back down 2 steps, can't hear it, back up 1, back down. So it's the same as doing a PTA, down 1, 2 up, until you establish a threshold. And that gives you an ACT score, basically. The ACT score correlates very, very well with speech and noise tests. It doesn't need a different language, so you can test it in any language. But importantly, what it does is it gives you recommendations about what to do with hearing aids. So if you happen to use Diatec or Interacoustics kit and you've got Oticon hearing aids, it will actually pull these through and it will change the noise reduction and other features of the hearing aid automatically for you. If you haven't got those, I haven't got time to go through all of this, but it will tell you what to do with the hearing aid parameters. So for example, somebody with very, very good speech and noise ability, you do not need to crank up all the clever features on the hearing aid because you want to keep the signal clean, because that person has the cognitive ability to make use of that information. Somebody with poorer cognition hasn't got that ability, so you need to do different things. You need to increase the SNR much more and do other things with the parameters to clean up the signal so that they can process it. That could be another 45 minutes on its own, so we won't go there right now. So if you want to do a speech test, that's another way to do a speech test. It's an effective way to do it. It's a 2-minute test, really easy to perform, gives you lots of useful information like speech testing, and helps your counselling, again, in setting expectations. So somebody with a poor score isn't ever going to get perfect speech and noise ability, whatever you do with a hearing aid. So it helps you explain what's going on to them. Zap through that last bit, sorry. So in slightly over time, 5 minutes over time, sorry, I've got to Q&A. If anybody's still there and hasn't dashed off to clinic, if anybody's got any questions, feel free now, throw them at us.
Can you see any, Zoe?
Not yet. If anyone has any questions, if they want to add it to either chat or Q&A part, and then I'll keep an eye on those.
Thank you very much, Richard. Well, for me, it was massively interesting, and yeah, it's very informative. So thank you very much.
No problem, anytime.
Yeah, we know people probably do have to dash off and see clients now. So yeah. Okay, I think if there's any questions, they'd be up there already, wouldn't they? So thank you very much for joining us, everybody.
Just to your initial question, you asked about BSA protocols.
Yes,
it is on our list. I'll take my Diatec hat off and put my BSA hat on.
Okay.
It is on our radar, is on our list of things to do. Unfortunately, as BSHAA, BAA and BSA, we're all voluntary bodies, so we do what we can in the time we've got. It is on our list of things to do, but we do have a lot more important things to worry about, particularly paediatric audiology at the moment, and having guidelines in place for play audiometry, and in adult audiology actually having guidelines in place for hearing aid fitting, which covers some of this stuff. Is that a question?
Yeah, 100%.
Yeah, we've got a couple of questions actually. So one is, could you say something about requirements of aided tested, e.g. sound field?
Not sure what you mean by e.g. sound field.
While I find out who that was from, we've also got a question that said, how do we access I have AWRC?
So let me just share this again. Sorry, I can answer that quite quickly. If you've got AWRC, that's a MedRx system. Can you see the slides again?
Yes.
So you can try and contact me at Diatec. This is our sales map for UK and Ireland. We cover all of UK and Ireland. So anything to do with intraacoustics, MedRx, including AWRC, any questions, you can talk to your regional sales manager. If you just pop onto the Diatec website, we've also got a clinic team and a training team and a customer service email. You can direct those. You can if you've got any specific questions about bits of kit, any of those kit, including AWRC, please just contact one of those people or direct to me at Diatec.
And just to add to the question before, it was, could you say something about requirements of aided tested, e.g. sound field, testing people who are wearing aids? And that is from Christine Johnson.
So I think, so I've done quite a bit of aided, unaided and aided testing. So I'm assuming it's a question about aided versus unaided, if that's right. So, I mean, aided testing is fine. One of the issues with, which I've not really addressed or had the time to address, one of the issues with speech testing is calibration. So it's quite difficult to calibrate whatever piece of kit you've got, and there's a lot of variability in the way people do it. And actually some people are doing some strange things out there, which we've actually just started looking at within Diatec, of how we actually do our own piece of guidance for calibrating. So if you're going to do aided versus unaided, I'd just say be careful that you have calibrated the thing between the two. because people tend to turn things up and down a bit and can easily do aided versus unaided at different sound levels by mistake without realizing. So you've got to be a bit careful there. I showed you that outcomes of aided versus unaided. So, you know, if you're going to do aided testing of speech in quiet or speech in noise, people will generally do better. But the bigger their hearing loss, the better they will do compared to their unaided test. So if you're testing people with a mild hearing loss, there is a chance that it won't look dramatically better, aided versus unaided. That's not to say they aren't doing better with the hearing aid. It's because you are not really, in anything you do in audiology, unfortunately, you're not really replicating real life experience. You're doing a test in a room which may or may not be acoustically good or bad with a piece of kit with one sound. So remember, there are limitations to all the things we do, unless you've got 26 speakers in a circle and can do all of that funky stuff. But you know, most of us, you know, in our daily lives don't have either the time or the money to do stuff like that. I'm not sure whether that's the point you're raising.
And then the last question was about whether the slides could be available in a PDF format.
Yes, I can, because I did most of them at the BSHAA conference and already gave them to you. So I will give you these as well in a PDF format. Yes.
Brilliant. Thank you, Richard.
Thank
I'll
you.
send those to Zoe and Jayne today, so you can distribute them. Yeah.
Yeah,
That'd be great.
amazing. Yeah. Well, thank you again, Richard, for your time. I think it was very well received. So thank you again.
No problems. Nice to talk to you all again.
And you. Bye-bye.